Hi everyone, and welcome to Chapter 15. So Chapter 15 is on psychological disorders, and as I've mentioned in class, I am really excited for this chapter. As you all know, I'm currently enrolled in a clinical doctorate program, so mental illness and the treatment of mental illness is one of my passions. So in this chapter, we're going to review some of the more common psychological disorders and talk a bit about their symptoms and maybe a bit about their etiology, meaning where they came from. And then in the next chapter, in chapter 16, we're going to focus on some of the treatments and therapies that we can use to help alleviate the symptoms of these disorders. So when people think of mental illness, they often think of people who suffer from delusions or who behave in bizarre ways. However, in reality, most psychological problems are far less dramatic than the general public might believe, and they're also far more common. So it's said that approximately 1 in 4 or 1 in 3 people will experience some form of mental illness in their lifetime. So the rates are actually a lot higher than people believe. This chapter will examine both the milder forms of psychological disturbance as well as the much more severe disorders, and we'll also discuss why it can be so hard for psychologists and psychiatrists to agree on a diagnosis. So the very first module, which is what we're going to be focusing on today, we're going to talk generally more about how we diagnose mental illness and how we define it. One of the most common worries that people have is thinking, am I normal? In reality, we know it's normal for everyone to have problems. The difficulty is determining when the normal problems cross into abnormal ones. So our first module is on defining and classifying psychological disorders. So over the past millennium, our understanding of psychological illness has come a long way. In the Middle Ages, people who would now consider mentally ill may have been viewed as possessed. So they literally thought that, they had some kind of demonic presence potentially inside of them. And the treatments for mental illness were directly based on this model of illness. So things like brutal imprisonment, torture, and even demonic exorcism were used to attempt to treat what we would now consider mental illness. Thankfully, times have changed, and the ascension of scientific thought has caused explanations to shift from demonic possession to physical illness. So we now employ what we call a medical model in describing and kind of understanding mental illness, and we'll talk about that a little bit later on. Asylums, which were residential facilities for the mentally ill, were set up across Europe. The general goal was to cure whatever bodily affliction gave rise to the patient's symptoms. But many of the techniques at that time were still questionable and generally ineffective. So even though they had shifted from thinking it was kind of a demonic possession to more of a physical illness, they still weren't really effective in terms of knowing how to treat the symptoms of mental illness. The fortunate change in society's approach to treating mental illness was brought about by Philip Pine and Dorothea Dix. So they advocated for moral treatment, which led to patients being treated with kindness and decency. But unfortunately, there were still few effective treatments. They were treating them better, but they still weren't necessarily alleviating all the symptoms. And I believe your textbook, this version, has taken out the little section on Pine and Dix, but I wanted to keep it in here because I thought it was kind of nice to see how we've evolved over time. By the 1950s, approximately 66,000 Canadians were living in psychiatric hospitals, but in 1955, things began to change. A drug named chlorpromazine, I have to kind of brace myself to try to say that, was introduced, and suddenly even people with severe psychotic illness were able to function independently. So it was one of the first kind of antipsychotics approved for use. The success of this and other medications led to widespread deinstitutionalization, which was the movement of large numbers of psychiatric inpatients from their care facilities back into regular society. So they were no longer being kind of locked up in asylums. Even once those care facilities became more humane, once we had appropriate medication to help us treat mental illness and to kind of combat some of those severe symptoms, it was much more likely that patients would be released kind of back into society. Unfortunately, deinstitutionalization also has its downsides, so many former inpatients quit their medications and slip back into their disorders. So unfortunately, one of kind of the, positive things about being in some kind of institution is that you do have people supervising you and making sure you're taking your medications. And unfortunately, a lot of people who suffer from mental illness, particularly with kind of psychosis and things like that, they're not really great in terms of their medication adherence at times, unless there's somebody kind of keeping track of that. So unfortunately, helping people reintegrate into society wasn't a central part of the psychiatric approach to treating mental illness. So the psychiatric meaning kind of the more medical approach, and though it was effective at times, they didn't really track the people after they left and make sure, follow up on whether or not they were adhering to their medication schedules and things like that. So the approach was based heavily on the medical model, which I mentioned a minute ago, which sees psychological conditions through the same lens as Western medicine tends to see physical conditions. So there's a set of symptoms, causes, and outcomes, with treatments that are aimed at changing the physiological processes in order to alleviate the symptoms. In recent years, however, this medical model has given way to the biopsychosocial model. If you were in my classes last semester, we kind of added on to that, and by that I mean in my own classes for my program. We kind of added on to that, and we call it the developmentally informed biopsychosocial cultural lens. So we want to not only make sure we're taking into account the biological factors, the sociological factors, and the psychological factors, but also that we're taking into account things like culture and the stage of development that the person is at. So you should be kind of taking a more rounded approach when looking at mental illness and defining it and figuring out how to best treat it. So here's a little table that kind of goes through some of those biological, psychological, and sociocultural factors that can influence both physical and mental disorders. I believe this table was actually taken out of the newer edition of the text, but again, I want to keep it in because I thought it was really nice to see kind of some examples of those three domains. So if you look at something like diabetes, obviously we know that that's a kind of a physical illness, and you can see how it could have biological, psychological, and sociocultural influences. And the same thing with something like major depression, which is known as kind of one of the more common mental illnesses. You still see that we have biological, psychological, and sociocultural influences that can contribute to the onset, maintenance, and even, treatment when we're able to target those factors of mental illness as well. So one of the trickiest problems in the mental health field has been determining how to reliably identify who has a mental disorder and who is simply exhibiting abnormal behavior. So the key criterion used by psychologists to decide whether a person has a disorder is whether the person's thoughts, feelings, and behaviors are maladaptive. So maladaptive essentially means they cause distress to oneself or others, they impair day-to-day functioning, or increase the risk of injury or harm to oneself or others. Abnormal psychology is the name given to the psychological study of mental illness. So, if you want to study and treat mental illness, you're probably going to go into some kind of counseling or clinical psychology program, but the whole area in general of kind of researching mental illness and trying to figure out what the best approaches to treatment and such might be, that whole field is kind of referred to as abnormal psychology. This, as you can see by the little asterisks at the top, it's a little different than some of the other slides, is actually stuff that was from the older textbook. So it's not even the older version of this textbook, but the one that I used before. And I like to keep this in here, even though the asterisk is kind of implying that it is from an old textbook, and therefore I won't really be testing you on this specific definition. But I really like the way that they define mental illness. So I wanted to kind of keep it in there just to give you, a couple different perspectives on how we might define mental illness or mental disorder. So one issue we've had with defining the term mental disorder is determining whose point of view we should take. That of society, those affected by the troubled individuals, or the perspective of the troubled individuals themselves. So we know that it's not just the person who's impacted by the mental illness, it can also be the people around them and also kind of even society as a whole. So there are three factors that we can kind of look at when we're determining whether or not we're going to define something as a mental disorder. We can look at mental disorder as a violation of cultural standards, which emphasizes rules and roles of the culture. So there are many rules specific to a particular time or group. So for example, visions, while seeing things that aren't there is considered abnormal in our culture, there are some certain types of cultures in which that's actually considered to be a positive thing. So based on the culture you're a part of, that would kind of help determine whether or not you seeing a vision, perhaps of a dead relative, is considered, normal or disordered. The second is mental disorder as emotional distress. So in terms of the person suffering, the behavior is deemed unendurable or upsetting for some. Behavior that is deemed unendurable or upsetting for some may be normal to others. So it really depends on whether or not that behavior is particularly distressing to the person who is engaging in it. And then mental disorder as a behavior that is self-destructive or harmful to others. So emphasizes the negative consequences of a person's behavior. It may be harmful to the individual sufferer or may be disruptive or dangerous to others. So it can put, certain mental disorders can put not only the sufferer at risk of harm, but also other people at risk of harm. I will kind of follow that up by saying there's a lot of stigma surrounding mental illness, and people who suffer from mental illness are far more likely to be harmed themselves than to harm other people. But there are rare circumstances in which the symptoms of a disorder might cause someone to kind of act violently towards other people. So we do kind of keep that in there as a potential part of the definition. So our definition, and again, this is from the old text, so you don't really have to kind of memorize this, but just kind of interesting, and I like the way that they define things. So they said mental disorder is any behavior or emotional state that causes a person to suffer, is self-destructive, seriously impairs the person's ability to work or get along with others, or endangers others or the community. So by this definition, many people will suffer from some type of mental health problem over the course of their lives. And like I said, it is a very, very common occurrence, even though kind of there are myths surrounding that. People think that it's far less common than it actually is. So nationwide surveys in the US have found that only 7% of the population suffer from seriously debilitating mental illness, but that nearly half temporarily fall prey to severe anxiety, depression, drug abuse, or other problems at some point in life. And in Canada, we actually see that mental disorders are the leading cause of disability in people aged 15 to 44. So during that, young adulthood to kind of middle age, we do see that mental illness is considered kind of the leading cause of disability in Canada, which is pretty significant. So now we're back to the notes from the new textbook. So the attempt to develop an adequate system for diagnosing mental illness goes back to at least 1840. And by 1917, a guide for mental hospitals called the Statistical Manual for the Use of Institutions for the Insane had been written. As you probably know, that title was not the nicest way that we could have described things. And so in 1952, the American Psychiatric Association created the Diagnostic and Statistical Manual of Mental Disorders, also known as the DSM. And so this was a standardized manual to aid in the diagnosis of disorders. And the first edition described the symptoms of 106 different mental disorders. So we have revised this book several times over the years, and it is still kind of our main go-to today. But that original publication in 1952 was really influential because it was one of the first times that we had kind of gathered up all the information that we knew based on the research evidence about this phenomenon that is known as, mental illness. So the purpose of developing this manual was to provide mental health workers with a reliable method for diagnosing mental illness, and it was rooted in a psychobiological view. So not only does it consider psychological factors, but also biological factors that can contribute to the onset and the maintenance of mental illness as well. It's often referred to as the Bible of psychiatry, and it is very important in both psychology and psychiatry. The DSM-5, which is our current edition, was actually one of my textbooks for my courses last semester, so I own it, and honestly, I had wanted to buy it long before that, but it is quite an expensive book, so I was finally able to justify buying it for myself. It's a fantastic resource, and yeah, we basically studied it for my adult psychopathology course, so it was one of our kind of core textbooks for that course. So it aims to provide clear diagnostic categories so clinicians can accurately identify, study, and treat mental disorders. Disorders are clustered into the following chapters. So we have neurodevelopmental disorders, emotional disorders, somatic, externalizing, neurocognitive, and personality disorders. The DSM has had an extraordinary impact worldwide. As I kind of mentioned before, the first edition had only about 106 diagnoses and roughly about 86 pages, whereas the current, and I checked mine the other day when I was kind of revising these notes just to make sure, and my version as well does in fact have 947 pages and about 400 different diagnoses. So it is much longer than it used to be. And so in order to aid diagnoses, the DSM describes three important pieces of information for each disorder. So it always is going to give us a set of symptoms, the etiology, which as I kind of mentioned before is the origin or causes of the disorder, or potential causes at least, and a prognosis or prediction of how the symptoms will persist or change. So for each disorder, not only does it list those symptoms and possibly where it came from, it also lists, how resistant it is to treatment, how likely it is to improve, what types of treatment have been kind of proven effective based on the research evidence. So it kind of it really is, like it says at the beginning of this, kind of like the Bible of psychology or psychiatry. It has all of that information kind of brought together in one convenient format. And I actually have access to an online version of it as well, which is really cool because you can literally just kind of click on whatever chapter you want and it goes immediately to that, and you can kind of scroll the web page and read it. So it's been made really easily accessible for those of us in the mental health professions. Of course, the DSM is not without its criticisms. So it has received a great deal of criticism over the years. The diagnostic process is very subjective, and although the DSM offers lists of specific symptoms that are indicative of certain disorders, this doesn't entirely solve the problem. For example, a clinician still has to subjectively determine if a patient is exhibiting a symptom and whether it is severe enough to be symptomatic. So it might be that, they're exhibiting something that could be potentially disordered, but maybe it's not quite at a level of severity that would be anything other than normal experience. Obviously, for example, if somebody dies, people around them become sad and they go through grief, but if that grief is more kind of prolonged, it goes on too long, or it is much more extreme than usual, that's when it might be considered disordered. Whereas something like the normal experience of grief and feeling sad after a death is just that. It's a normal experience and not something that we would consider a mental illness. And also another problem is that different disorders often share many common symptoms, so two clinicians might make a different diagnosis. This is actually really common and it can be really detrimental. For example, and I'll talk to you about this in the next module when we start getting into the mental disorders, but a lot of people are misdiagnosed with bipolar disorder, which I'm sure you've all heard of, when in fact they might actually be exhibiting the symptoms of borderline personality disorder. And the treatment for those two conditions is very different. One of which responds pretty highly to medication, whereas the other one is more likely to respond to certain types of psychotherapy. So it can be really devastating if, just because the symptoms overlap, the patient is misdiagnosed with the wrong disorder. An additional weakness is that there's a fine line between whether or not a person is considered to have a disorder. So for example, it could be, 4 or 5 symptoms that you have to have. So if you have 4 out of 9, you may be considered kind of fine and not disordered, whereas if you have 5 out of 9, then all of a sudden you're considered to have this mental illness. So it's very kind of, it's very subjective in a way when you're looking at it and you're trying to determine as a clinician whether or not the person fits these particular criteria. And there are some disorders, and again, I'm going to use the example of borderline personality disorder a lot because it's my personal research interest and something that I'm very passionate about learning about and treating. And so in order to be diagnosed with BPD, borderline personality disorder, you have to have at least 5 of 9 symptoms. So what that means is that one person could have one, certain 5 of the 9 symptoms. The other person could have 1 overlapping and the 4 other symptoms, and they could still get the same diagnosis, even though their presentation is virtually completely different, with the exception of maybe 1 symptom. So it can be very subjective whether or not somebody's diagnosed with the same disorder, and it can also kind of impact whether or not we're looking at 2 people with the same diagnosis, whether we consider them to be accurately diagnosed based on the fact that they may have very different symptoms presenting. So the DSM, by definition, implies that disorders can be objectively defined, which has potentially contributed to the stigmatization of mental illness. So as we know, there is a great deal of stigma surrounding mental illness. If you hear that somebody has a certain mental illness, a lot of people might think negatively of them because of it, or have certain myths and things that they've heard that are completely untrue, but still create that really negative perspective of mental illness. So finally, another critique is that issues have been presented concerning giving mental health workers more labels to diagnose clients with, which is not necessarily a good thing and may lead to overdiagnoses. So for example, in the case of ADHD, and I'm sure you've all heard of ADHD before. I believe we'll talk about it a little bit later on, but essentially what happened is if you look at the prevalence of ADHD from say 2003, 2011, the prevalence apparently increased by 35%. which is a very, very high amount. So what we're saying in that case is perhaps because we gave, this label, we included it in the DSM and we gave these symptoms, that then clinicians are much more likely to take those symptoms and kind of come to a diagnosis for a client who might not necessarily exactly fit that description. The boundaries as well between normal problems and mental disorders are fuzzy, and it can often be difficult to determine, and many psychological symptoms fall on a continuum from mild to severe. So one of the major kind of, not arguments, but I guess debates that's going on in the mental health field right now with respect to the DSM is whether or not we should be looking at mental illness as kind of categorical, so you either have it or you don't, or whether we should be looking at it kind of on like a dimension. So, if they have like mild versus moderate versus severe. And right now, the majority of illnesses are basically described as you have it or you don't, whereas a lot of people would argue that it should be more of a spectrum. However, all this being said, when the manual is used correctly and diagnoses are made with valid objective tests, the DSM is believed to improve the reliability of diagnosis. So it's a great resource to have. It's something that, any mental health practitioner should be familiar with. But at the end of the day, you can't just look at the symptoms of a disorder in the DSM and then basically tell somebody they have it. You should be using other measurement techniques as well. So there are tons of different questionnaires and resources out there for mental health practitioners to help them make accurate diagnoses. And they can use the DSM to kind of help improve the accuracy of these diagnoses. So it shouldn't be the only thing that you're using to diagnose. So now we'll talk a bit about labeling in mental disorders. Diagnosing a person as having a particular disorder can be very helpful. So it is hoped, and it is the case a lot of the time, that receiving a diagnosis will make people more likely to seek and receive effective treatment, and it should help to facilitate communication between mental health professionals. However, unfortunately, giving someone a diagnostic label can also have its drawbacks, such as biasing how people will subsequently interpret the person's actions or experiences. So if you know that, somebody has depression or somebody has anxiety or somebody has ADHD, that might kind of affect how you interpret their behavior. Oh, they're only doing that because they're depressed. Oh, they're only saying that because they're anxious. And so unfortunately, sometimes it can cause us to judge people negatively. As well, it can sometimes change how people feel about themselves. So it can become kind of a self-fulfilling prophecy, which we've talked about in other chapters. So if you know you have depression and you know that depression makes it harder to kind of get up and do things, you might lie in bed thinking, well, you know what, this is the way I'm supposed to be acting. I know that based on this illness that it's harder for me to get things done, so therefore I'm not even going to bother to try. And of course that creates that self-fulfilling prophecy. In a very interesting and daring study in the early 1970s, 8 people who were volunteering with David Rosenhan decided to get themselves committed to a psychiatric hospital. So it was a really interesting study. So Rosenhan was an American psychologist, and basically what he did is get a bunch of people to fake hallucinations so that they were able to gain access to a psychiatric hospital to get admitted. So they went in for assessment and they started saying that they were seeing things and talking about these hallucinations that they were having. And so they were all committed and diagnosed and given antipsychotic medication. And actually what they found is once the people were diagnosed and kind of admitted to the hospital, it was very, very hard for them to convince the people who were treating them that they weren't actually mentally ill. So even though they faked the illness in the first place and made up the symptoms, the people at the hospital then started treating them kind of everything that they did as an aspect of their diagnosis. And they didn't believe them when they tried to say, hey, we're actually not mentally ill, we just did this as an experiment. So you can kind of see how that goes along with what we were just talking about that kind of diagnostic label having the power to cause people to view others in a certain way. Psychological disorders may not present in the same way across cultures as well, and a lack of understanding of cultural differences may lead to misdiagnosis. So for example, I'm sure you've all heard of post-traumatic stress disorder, or PTSD, which is a common psychological illness involving recurring thoughts, images, and nightmares associated with a traumatic event. It induces symptoms of tension and anxiety, and it can seriously interfere with many aspects of a person's life. And I know that this is something that's very commonly portrayed in the media and movies, things like that. But despite the fact that you would think the cognitive symptoms of PTSD are seemingly universal, research has found interesting differences in the cognitive and emotional symptoms, basically based on the culture that a person lives in. So for example, reoccurring personal flashbacks seem to be more common in individualistic cultures. So you've probably all kind of heard the story of the person who comes back from war, the soldier, and they have severe PTSD, so they keep having flashbacks to kind of when they were in the war zone. And so those type of personal flashbacks seem to be more common in individualistic cultures like our own, whereas in more collectivist cultures, people report recurring worries about the welfare of families and communities. So in the collectivist culture, where the harmony of the group is kind of the most important aspect, people are actually more likely to experience worries about others around them and the groups that they're a part of, rather than having those flashbacks of their own personal experiences. We've also seen that the rates of anxiety disorders can vary by up to 3 times depending on where someone lives. And rates of schizophrenia are higher in African and Afro-Caribbean immigrants than in other immigrant groups. So for example, when we're looking at anxiety, we do see much higher rates in Latin American cultures, whereas there are much lower rates of anxiety reported in East Asian cultures. And so there are a lot of differences just based on, the prevalence of disorders in certain populations as well. Finally, in addition to differences within certain illnesses, there are also some disorders that are considered to be culture-bound syndromes. So this basically means there are certain disorders or expressions of distress that are recognized across a given culture, but that tend not to appear outside of that culture. And it's not really talked about in the textbook, but I would like to point out that when we talk about things like anorexia and bulimia, some of those seem to be much more prevalent in cultures where, there's a lot of media exposure. So when you look at cultures that are kind of relatively untouched by modern society, you're far less likely to see those sorts of disorders. So it can kind of show you how that kind of cultural and societal impact can be really detrimental to the prevalence of mental disorders at some points. And another thing that I like to point out are the specific culture-bound syndromes for other cultures. So for example, there's one called ataque de nervios, which is a Latin American disorder that involves trembling, uncontrollable crying or shouting, fainting, and even aggression at times. And then I'm going to butcher the pronunciation of this next one, but Shenjing Shuaro. And that's a disorder in Mandarin Chinese. So it involves extreme fatigue, physical weakness, pain, and problems with relaxation after periods of mental effort. So it seems like, if you undergo a period of stress where you're really having to kind of tap into those cognitive resources a lot, it can lead to some physical ailments as well there. So you can see how there are certain disorders that kind of only seem to exist in certain cultures, and we don't really see them outside of others as well. And that was one of the major issues with some of the first versions of the DSM, was that they failed to take into account these culture-bound syndromes. But I am pleased to say that they're definitely improving on that in recent editions, and they do talk a lot more about culture-bound syndromes now than they have in previous texts editions, I guess, of the DSM. So as I mentioned, we're going to come back to ADHD. So classroom behaviors is one area that present diagnostic challenges for psychologists and educators. All children act out at times, but some children's activity in the classroom is outside of the normal range of behavior. So many children are now diagnosed with what we call attention deficit hyperactivity disorder, or ADHD, which is a developmental disorder in which children show inappropriate levels of hyperactivity and impulsivity while also having problems maintaining their attention to people or activities. So they might fidget a lot, they tend to be very talkative, they fail to listen, they have a really hard time concentrating on tasks. There are also issues with emotion regulation as well that aren't usually kind of highlighted as frequently. And since ADHD was added to the DSM-3 in 1980, the diagnoses, as I mentioned on that previous slide, have skyrocketed in North America. So it's really interesting to see that not only have they kind of increased exponentially in that time, but it seems to be primarily within our culture. So if you look at Europe, for example, it's actually only diagnosed 10% as often, which is a really kind of dramatic difference. So one of the questions we might ask is our children being medicated for disruptive activity that is still within the normal range of childhood behavior? So as we mentioned with the DSM, it does make things much more easy to diagnose and kind of put a label on, and unfortunately that may be happening at times with this particular disorder. So that's just one example of how we have to be cautious with the information that we take from the DSM. And one final slide for this module, that was more about the application of psychological disorder to the diagnosis to the classroom setting. Now we'll talk about the application of psychological diagnoses to the law system. And so there is something called the mental disorder defense. So the lack of diagnostic accuracy, so the fact that it is kind of, I won't say common, but it does occur fairly often that there are issues in diagnosis and misdiagnosis, and that can play a big role in the criminal justice system as well. So you've no doubt heard of trials where the defendant has pled not guilty by reason of insanity. In Canada, the insanity defense is now referred to as the mental disorder defense. It does not deny that the person committed the offense. So it's still saying that the person did what they're accused of, but it claims that the defendant was in such an extreme abnormal state of mind when committing the crime that he or she could not discern that the actions were legally or morally wrong. So example, if they were in a severely dissociated state, if they were having hallucinations or certain delusions, it might cause them to literally not realize that what they were doing is wrong. So despite common myths, because a lot of people say, oh, that's just letting people get away with crimes, but the mental disorder defense is extremely difficult to use and use successfully. So it is used infrequently, so less than 1% of cases people even bother to try to use this defense, and it is very rarely successful, so less than 25% of the time. So we've got it only being used less than 1%, and then it's only working, less than a quarter of the times that it is used. So it isn't something that's common. It isn't something designed to get people off the hook. It can be applied in certain scenarios where people literally were not able to kind of process the effects of what they were engaging in at the time. It's sad, and it doesn't, absolve the person of responsibility for the crime in a way, but at the same time, it isn't really fair to put somebody in jail for life if they honestly did not realize that what they were doing was wrong at the time. So that's it for Module 1. I know I kind of added a bit of extra information in there, so I apologize for that. As I mentioned, this is kind of my field, so I will be adding little tidbits in along the way, and sometimes kind of going off track, so I know I kind of lost my focus a few times there, but hopefully you enjoyed the information. So next up, I believe we're discussing personality disorders. We have an entire module on it, which I'm really excited about because, as I mentioned before, personality disorders, specifically borderline, are kind of one of my major clinical research interests. And now, not only do we get to cover the 4 disorders in Cluster B, we actually get to cover all of them for the personality disorder section. So I will end this here, and I will talk to you in that next video.